Thank you again for the warm introduction. It is an honor to be here, and I love the topic of dismantling diabetes. We know that diabetes is a significant disease that has attacked the African American community specifically in a very unique way, where I remember as a kid watching my grandfather obviously go through type 2 diabetes and give himself insulin injections. And back in the late 70s, early 80s, it was more so, it seemed like a harpoon needle that he was using at the time. And so we'll get more into that as we talk about treatment next week. But we're going to talk today about this concept of sugar. And just to recap what we talked about last week, we talked about diabetes, what it is not. Certainly it is. We talked about type 1 diabetes versus type 2 diabetes. We talked about specifically in African-American community, the history of the very unique history African-Americans have had in this country, which has lended itself to disproportionate numbers in regards to disease, and specifically that has been seen in this particular disease of diabetes, and also the relationship to weight. We talked a little bit about how obesity lends itself to an increase in insulin resistance, and also leading to more diabetes, and what you kind of needed to know about the disease. And today we're going to talk a little bit about this concept, sugar. Obviously, no sugar baby really came from what I would always hear in terms of my grandmother, and certainly some of your family members, I'm sure, have said it as well. They did not refer to diabetes as diabetes per se, or diabetes mellitus, as the whole name is, or type 2. They said it was basically sugar. Such and such has sugar. And the reason they said that is because there was a correlation between this disease state and the amount of sweets that one would eat. So when you would get ready to eat cakes and pies and other confections or sweets, there was a direct relationship between, people just knew, hey, if you had too much of that, it wasn't a good thing, and it could lead to sugar. But what we understand is, again, as I mentioned last time we were talking, is that diabetes in and of itself is disease of insulin resistance or insulin deficiency. Insulin deficiency is that in the pancreas has certain cells, specifically the beta cells that are a part of it, that produce insulin. And insulin's sole job one of insulin's job is to attach itself to our cells and make sure that sugar can go into the cell to help in the functioning of that cell, that cell is able to function. It has just like your car needs gasoline in order to run, our cells need glucose in order to run and operate effectively. Okay. So as I often tell people, sugar in and of itself is not to be completely demonized, but the way our bodies are able to utilize or not utilize sugar or glucose is the problem. And so that's really where this term came from. And as I kind of get more so into it, what we just want to hit you guys with a few more statistics is when you look at our country, when you look at the United States of America, and you look at the 2015, it was more of a light red all over the U.S. In the middle parts, Colorado. It was thought that that it was the prevalence of diabetes was not as bad, but the projection by 2025 is that there's going to be completely dark red, especially in the Southeast area, and in the South, completely red, and prevalence just terrible all over the United States. And you're talking about 29.1 million, 9.3% of the US population. And the significant number to me is the 8.1 million undiagnosed. Those are walking around that have type 2 diabetes that are undiagnosed. And the reason that's bad is because sugar, if you will, predisposes us to microvascular and macrovascular disease. Okay, and so microvascular, as we talked about last time, is the disease of small blood vessels within the body. That's going to be in your kidneys and your eyes. And then macrovascular disease is the disease of the cardiovascular system, your heart, affecting your heart, and then the nervous system, the microvasculature affecting the nerve system, which affects your the whole amputation issue. And that's why diabetes is one of the #1 causes for amputations, kidney disease, eye disease, and also cardiovascular disease as well. There's a cardiologist I think I mentioned that I work with that said you could put it on a clock from the time that you're diagnosed with type 2 diabetes. You're about 20 years away from a cardiovascular event, and he basically said it's like putting it on a clock. And the scary thing is you now have teenagers being diagnosed with type 2 diabetes. And so if you think about it, a 15-year-old diagnosed with type 2 diabetes, that's to say by the time that that teenager is 35, they could have their first cardiovascular event if their diabetes is not controlled. And again, why that's significant is whatever you're seeing, when you look holistically, think about the effect that it has on the 13% of the population that African Americans represent in our country. That typically whatever affects the whole affects us worse when you take in consideration the history and some of the disparities and social determinants of health issues that have uniquely affected our communities. So that's something that we have to definitely think about. And when you think about the effect of obesity, I wanted you guys to look at from 1980. We know that obesity is a huge driver of diabetes all over the world, but it's specifically in the United States. And you look at 1980, the United States in and of itself was in yellow, and you can also look at other countries. But over time, up until 2016, you see this darkening representing more obesity. But that has correlated to an increase in numbers in type 2 type 2 diabetes prevalence all over the world. And so obesity has a significant impact on it because, again, as you get bigger per se, there is a increase in insulin resistance where our bodies does not use the insulin that is being produced, and because of that, that predisposes us to type 2 diabetes getting worse as well. And what we also know is the top 10 countries where people with diabetes, 387 million people have it across the world, and that number has increased. USA is represented, the third highest number behind China and India. And we also know that there's been this increase that is from 1980, and I know it stopped at 2011, but I wanted you to see how it is steadily increased. And that has been associated with our diets, what we're eating, what we're putting in our bodies, the quality of foods, the impact of those foods, and how that has worked to put us in a situation where disease has grown. And now the prevalence of diagnosed diabetes has gone up as well. And we also know that the projection in terms of diabetes prevalence by 2050 is that, which is scary, is 1 in 10 in 2010, but by 2050 it's going to be between 1 in 5 and 1 in 3 in terms of diagnosed and undiagnosed diabetes, which is scary. And we know that the aging of the US population has a lot to do with it. And we know that the higher risk minority populations, for which African Americans we are a part of, and then the declining mortality among people with diabetes all play a role in the whole prevalence continuing to go up. So total diabetes prevalence from 14% in 2010 to a whopping 33% of our population. And then if you couple that with by 2030, if nothing changes, it is thought that 50% of our population will be obese. The obesity, as I mentioned earlier, feeds into the diabetes prevalence. So that's why we have to all do everything that we can to fight against this, to move towards being as healthy as possible. And I wanted to talk a little bit about the continuum of what happens and what's taking place. And when you look at the normal glucose regulation, and I don't want to get too deep, but I think it's very important to understand. And I want you to look in the middle where you see that little orange and it says high BG level. And basically when you eat and you take in a meal, your body's going to take the sugar from the meal or the glucose from the meal. And then your pancreas is going to respond and release insulin into the blood, a compound that's going to be released. You see it there, insulin, and its responsibility is to help get the glucose into muscle cells, okay? And then the excess the liver converts to what's called glycogen, and that's like a storage system, right? That's a storage system. I mean, our bodies are so intricately designed that it's amazing. Liver creates glycogen stores to store, and then your blood glucose level in your bloodstream falls, and then less insulin is produced, right? And you're at homeostasis, which means you're at a nice pace. You're going the speed limit, okay? You're not going too high and you're not too low. You're not going below the speed limit and you're not going above the speed limit. You're kind of right there, okay? And that's what homeostasis represents. And then when your blood sugar levels go low, your pancreas, your alpha cells release what's called glucagon into the blood. Then those stores of glucagon break down in the liver and give your body the sugar that it needs, so you can continue to function right there in that homeostasis. So you can stay at 50 miles an hour. The problem again of type 2 diabetes is that you lose the ability to have that regulation. And when you can't have that regulation, you go into what's called hyperglycemia, and you have higher blood sugar levels all over the body, and these are the areas where you see effects. It affects negatively your brain, your fat stores. You get bigger. You have increased production in your liver. You have the uptake into your skeletal muscles go down. Your kidneys can get damaged because it affects your ability to reabsorb glucose, and the excretion of it throughout the outside of the body is messed up. Your alpha cells dysfunction. That's where glucagon is released in your pancreas. Your beta cells, they decrease in the release of insulin. And then there's a problem in the gut with what's called the incretin effect. And so that's a whole nother concept that's a part of it as well. But the gut is affected negatively as well by hyperglycemia. And here, all I want to show you here is when you see up top, down below represents when a person is diagnosed with pre-diabetes, right? The doctor says, hey, you're pre-diabetic. That means you're on the runway for type 2 diabetes. But as time goes on and you go into full-blown diabetes in terms of your diagnosis, and then an uncontrolled hyperglycemia, all these things are happening in your body. How your body responds to after you eat a meal and you take glucose in, your body responds. And then when you're fasting, you're not eating anything, but your body still has a fasting blood glucose level, which typically starts after 12 a.m. up until early morning. That's when you're fasting. And that's why your doctor says, hey, don't eat anything. Come in, let's get your blood test so that we can figure out where you are. And then what you see here is that the green line down below represents insulin resistance. From the time you're pre-diabetic, insulin resistance is going up. It's going up, right? Then your insulin levels are gradually going down, right? Your incretin effect sort of goes down, and then your beta cell function, the beta cells are responsible for releasing insulin. They go through a slowed death, okay? And they slowly die, which lowers your ability to create insulin at all. And that's how people go into full-blown type 1 diabetes when they have beta cell death. And that typically happens earlier. And remember, that only is 5 to 10% of the cases of diabetes, but 90 to 95% of the cases of diabetes are type 2 diabetes, which we're talking about today. And this is how the African-American population is significantly affected. And then when you get to the screening criteria, that there's the test that you have to go through. And so specifically, they say if you're overweight or obese, you have one of the more risk factors, you're a first degree relative with somebody with diabetes, you have your high risk race, which African Americans, Hispanics represent high risk races, American Indians, also Asian Americans who are over a certain size in terms of their BMI, and having high blood pressure, having high cholesterol, women who have polycystic ovary syndrome, physical inactivity if you work jobs where you're sitting at desks all the time, and if you have clinical conditions associated with insulin resistance, where you severe obesity, and then as I mentioned last time, this acanthus nigricans, this condition where you have the darkening around the neck. And the great thing is that they're looking at kids even earlier for acanthus nigricans to see if that is an issue. And then we look at patients with prediabetes. They should be tested early, right? They should be tested early, and there should be continued tests. And then women who are diagnosed with problems, gestational diabetes, they should have lifelong testing at least every 3 years. And there has been reports in the African American community, you do see higher amounts of gestational diabetes. Everybody else should be tested at about 45 years. Okay, if your results are normal, testing should be repeated every 3-year intervals. And then also there's a concern if you have a risk of HIV, that there's a greater likelihood to have type 2 diabetes as well. And then adolescence is something that we have to think about as well, especially African American population. If you have youth who are overweight or obese or have other risk factors, that is something for us to think about as well. Or they have a history of it, maternal history of diabetes, or family history of type 2 diabetes in their first or second degree relative. But signs of insulin resistance, which again is going to be that darkening around the neck, the bumps on the back, the canthus nigricans, high blood pressure, high cholesterol, all of those things are things that we should be aware of and make sure that we're watching out for when we take in consideration how our family members and friends, and African Americans specifically, are impacted. And then A1C, what does that mean? Okay, A1C again is going to be your 2 to 3 month average of your blood sugars. It's going to give you a picture of where your blood sugars are. And when you have an A1C of 5.7 and below, that's considered normal. But when you're 5.7 to 6.4%, that's going to be pre-diabetic. When you're greater than 6.5, that is full-blown diabetes. So that's why we want to be very, very aware of what our A1Cs are, because again, that's going to give you a picture of what you're looking like over that 2 to 3 month time period. Okay. Rhonda, I'm going to stop now and see, is there any questions or any comments up to this point?
I don't see any questions in the chat unless someone wants to raise their hand to ask a question. Are there any questions from the audience? I'm not seeing any, so I guess we can forge ahead.
Excellent. So when we're taking consideration what this all means, again, A1C, that 3-month average, our fasting levels, they're going to fluctuate. But the A1C is really the indicator of where you are, because the fasting blood sugar level is really what the A1C is in terms of a representative of the average of over that time period, that 3-month time period that I mentioned. So that's what that is so important. So when we think about some of the guidances for what we need to do moving forward, again, if diabetes is a disease of insulin resistance, and that means there's a correlation between prediabetes and obesity, then that means we gotta be more aware of what we're eating, what we're taking in, and we talked a little bit about how food choices and options have changed over the years. But now we want to talk about some of the nutritional consideration for patients with diabetes and some of the things that we have to think about, right? You want to think about, if you have type 1 or type 2 diabetes, you have to have a different type of diet, because it can be reversed through good, healthy habits, eating habits, medicational use, and getting in an exercise. And I'm going to tell you, exercise does wonders, and we'll get into that in the next slides, for helping you to use the sugar that you're taking in. So energy balance from nutrition, we want to make sure you reduce energy intake while maintaining a healthy eating pattern to promote weight loss. What we know with energy balance is the food you're taking in versus working out and exercising. You want to burn what you're eating and taking in, and then you want to look at how, possibly eating less, and when you do that, it's finding the balance where you're eating healthier foods that help you to be healthier and not have all those excess sugar in your bloodstream. So That's about monitoring carbohydrate intake by carb counting, and then also having an ideal carb intake for yourself. And that's about vegetables, fruits, whole grains, legumes, and dairy products. Watching your the amount of dairy you're taking in, and finding out what the amount of fiber you need to take in a day, because fiber is going to be real good for helping you stay regular and making you sure you move towards being as healthy as possible. But those excess carbs are what is a part of kind of overloading our system with carbohydrates, because carbohydrates turn into glucose in the body as they're processed in our body. Protein is great for muscle development and growth. So we do need to take in protein, but lean meat choices and options, healthier meat choices and options, low salt meat options are extremely important. And then dietary fat, consume less than 10% of calories from saturated fatty acids, limit your trans fat, and omega-3 supplements are not necessarily recommended, but increase the types of food that have omega-3s, fish, at least twice a week. Those types of things. Healthy fishes are huge to take in as well. Reduce your sodium, the sugar, alcohols, finding safe levels. Alcohol being limited. Red wine is considered healthy from the standpoint of the skin of the grapes being really good for the cholesterol levels. And so, taking in consideration what you need to do from a nutritional standpoint and supplement and vitamins where appropriate, and certainly talking to your doctor about that. And from physical activity with children, at least 60 minutes of physical activity each day, encouraging that. And with adults, having 150 minutes per week of moderate intensity aerobic physical activity exercise is important. And then spreading that over 3 days within 1 week, and no more than 2 consecutive days without exercise. And then resistance training. And that's so important for type 2 diabetics, again, because that's about muscle development. How do I make sure that my muscles are using the glucose that I'm taking in? That's going to be extremely important. And then individuals, including those with diabetes, reduce your sedentary time. If you're working from home, we have more individuals working from home now than ever before. And really, we have COVID to thank for that, because it's changed the way we work. But again, what does that come along with? What is that associated with? And if we're less active, then certainly that could contribute to an increase in insulin resistance, obesity, thus an increase in type 2 diabetes as well. So when we think about insulin, what does insulin do, for us, right? And, just to answer the question, when you think about insulin, again, it's going to stimulate glucose uptake into the muscle and into the tissue, fat tissue, so it can be used. It's going to help to make sure that the creation of glycogen, and you remember I was talking about those sugar stores in the liver to be used at a later time. It's going to inhibit what's called hepatic glucose production, or gluconeogenesis, where you have to produce glucose when you don't have the glycogen stores. So your body will begin to break down fats. It will break down muscle in order to get sugar from somewhere, because the cells desperately need it. So again, we cannot completely demonize glucose because it's needed for the function of our cells. However, we don't want to go into gluconeogenesis, where the body has to say, well, hey, I'll pull from some of your muscles, I'll pull from your fats, I'll pull from wherever I can in order to give the energy to the cells that the body desperately needs. Then reduce insulin secretion from the beta cells signals to the alpha cells glucagon secretion to break down that glycogenolysis that is so important to give what's needed. So insulin is extremely important. And when I get to the treatment in a couple weeks in our next talk, we'll talk about when you take exogenous insulin, how that exogenous insulin, or the insulin you get like at Walmart or you get at the pharmacy, why that's so important. So when you think about the approach, the American Diabetes Association last year set out this holistic person-centered approach to type 2 diabetes. And really it's about the components of care and the principles of care. The components of care has, medication for weight management. They understand that you gotta, take care of weight management. And now everything is about is cardiovascular risk a huge part of this? Do we have cardiorenal issues that we need to protect your cardiorenal, protect your kidneys from bad functioning? And then your medication for glycemic management. What medications do you need to take? And then that's surrounded by this whole other principles of care, which is about the psychosocial factors, the social determinants of health. Some of those issues I talked about last week, therapeutic inertia, let's stop inefficiently managing patients. That's hugely important. Consider your physiology, the practice and organization of care, reducing the risk of hypoglycemia, where when you're treating and the patient ends up bottoming out and going into hypoglycemia, which can be life-threatening. My wife actually had one of her best friends lost her fiance to type 1 diabetes and having a hypoglycemic episode that led to his death. So certainly, and I'm sure some of you have seen those types of things happen as well. So that understanding hypoglycemia and how to try to make sure we stay away from that as much as possible. Education support, language barriers, shared decision making. What are some of those things? And then, local healthcare setting and resources, and all those things are important. And basically seeing what factors need to be taken consideration as we treat patients. And I just want to highlight again, this is hugely important that we talk about, weight bias and some of the other things that in our community have been an issue where there's been a reluctance to go to the doctor to get checked out. We know that the persons with obesity avoid care because they're uncomfortable with healthcare practitioners and feel like they get unsolicited advice, or there's a negative attitude from the provider. And we know 68% of women with BMI greater than 55 delayed their care due to bias, even with insurance coverage. And 60% had increased risk of mortality associated with weight-based discrimination. So these are the things in the African American community that we have to continually talk about so that we are moving in the direction where our patients will feel good to move forward to be as healthy as possible. We also know down below, we know that persons of color, positive experiences with healthcare practitioners who identify as people of color. That's why, that's worked well. And that's why we want to certainly encourage our African American young people to consider the medical field so that they can be a part of the team of professionals that can help patients and also work to bridge the gap between a community that wants to be healthier but needs to sometimes have that relatability that's so extremely important. They admit substandard experience with white healthcare practitioners and saying that there's no noticeable difference between their experiences with a non-white or white healthcare practitioner. So that is something that we have to all take into consideration in terms of the minority experience as it relates to dealing with practitioners. And then this people first language. How do we talk? And that's one of the conversations from a healthcare practitioner perspective that we're talking about, avoiding dehumanizing language, using adjectives such as vulnerable, marginalized, or high risk. Avoid saying target, tackle, combat. Think of the needs of the population. Avoid unintentional blaming. And those are things within the healthcare community in order to promote health equity that we're having to think about and talk about even more. And lastly, I wanted to share this quote from this young lady that says, in general, racism is everywhere. The medical system is no exception. I feel like doctors put emphasis on outward experience far too much, to the point that they only identify medical issues by race, coupled with general racist ideas about people of color. And I've had to encounter people's disdain, dismissal, willful negligence, and haphazard dignity of care. I wonder how many of you are watching can relate to this or have heard something similar. And certainly I'm almost done, so I'd love to kind of hear some of your comments and your thoughts on that as well. And then she said, I wish others would understand that a lot of the weight people of color carry is that of the burden to fight for a dignified existence at every turn. And I also understand that the difference in size isn't equivalent to indifference to quality of life. So the No Sugar Baby is really about taking ownership of the fact that the word sugar is just a way in which I think it's almost like if I try to take the sting out of the snake, the fang of the snake, but it's still a snake. It's still a snake bite. It's still a poisonous snake bite when you think about diabetes. Just because sugar is the same word that grandma used to call us, she called us sugar, but she also called this disease sugar. We have to make sure that individuals realize we cannot be deceived to think that that is something that we shouldn't take seriously, because it's still a snake. If I defang the snake and think I can keep him as a pet, remember this, the fangs will tend to grow back. So that's what we have to be very careful in regards to this disease, helping individuals understand it, how to treat it, and how to move forward and be as healthy as possible. So I look forward to now just conversation and questions. And Rhonda, I'll open it up to you at this time, and we can
Sure.
go into
I,
conversation.
I, I love your analogies. The car. Thank you. So I think this slide is great to kind of ask the first question, and it's about how BMI is determined. So can you shed some light on that first?
Yes, BMI is determined by your height versus your weight. So the proportion of your height versus your weight, and that's how you get the number. So they measure your height, they measure your weight, and kind of create this number. And when you're at 30 and above, that's considered obese. Okay, overweight is from 27 to 30. But when you're over 30, that's when you're obese, and you have three different classes: class 1, 2, 3, and then 4 is anything above 40, which is considered severe obesity. So that's where BMI comes from. Now, remember, as I mentioned last, I've always struggled with BMI because I don't feel like it properly takes in consideration muscle mass. So individuals such as myself, I played college football. I'm still about 70, 75% muscle. They would consider me overweight or obese, but I still have a huge amount of muscle just because I was a former athlete. And so it doesn't always take that into consideration, but then, and that's the fallacy of BMI. And waist circumference is actually a real good tool to use, but what is true is that they have done research to look at uh, life expectancy associated with BMI levels, and also waist circumference as well. So that's where you really want to understand that the higher your waist circumference, the higher your BMI, sometimes the lower the life expectancy.
Great. And someone wants to know, how does diabetes affect fertility and pregnancy?
Wow, it does. It can have an effect. Diabetes can affect you from the standpoint that you won't be as healthy. You can be not as healthy to provide nutrition for the baby in terms of as you eat. It also you have a greater likelihood to have obviously gestational diabetes during the pregnancy, and then when you have gestational diabetes, you have a lot higher likelihood of having full-blown diabetes, and then also the child has a higher likelihood of developing diabetes. So yeah, it just puts you in a situation where it can tremendously affect your ability to have a healthy term. They can treat you with insulin while you're pregnant. So that is one of the things that can occur, but your goal is to be as healthy as possible. It's not what it was prior to insulin being discovered. It was kind of a death sentence, especially if you had type 1 diabetes. It was a death sentence prior to the discovery of insulin. So insulin certainly helps, but you want to make sure that you're as healthy as possible, in tip-top shape, so that you can carry the term as healthy as possible.
Great. And you all are welcome to ask your questions yourself if you want to raise your hand and do that. But there is another question in the chat, and someone wants to know, is atorvastatin as good as Lipitor?
Atorvastatin is Lipitor.
Okay.
Atorvastatin. Yeah, Lipitor is the brand name for atorvastatin. So, and those are statin medications, and they're used. And if you're asking from a brand generic perspective, atorvastatin generic should be as good as Lipitor. Lipitor is just a brand name for it. I did a couple years of research in hyperlipidemia medications, and atorvastatin is a great drug for lowering your cholesterol. And there are individuals who have hypercholesterolemia, familial hypercholesterolemia. So if need be, that's certainly something that you can take for lowering your cholesterol, because there is a relationship between cholesterol levels, blood pressure, and sugar levels in terms of cardiovascular events. So you certainly want to have a healthy cholesterol levels and blood pressure levels, in addition to trying to ward off and fight against type 2 diabetes.
Okay, great. And I want to go back to something you said earlier in the presentation. You talked about the role of carbohydrates, right, in the diabetes and so forth. And I wanted to kind of address the good carbs versus the bad carbs. So
Yeah.
can you explain that a little bit?
Yeah, there's certainly healthy carbs, are healthy carbs in our fruits and our vegetables. Even our vegetables have carbohydrates in them. I definitely think that there's some healthy carbohydrates to eat, to take in, because again, your cells need sugar. They do need glucose. So healthy ones, certainly can come from that. The unhealthy ones are going to be the high fructose corn syrup that we mentioned. Some of the which really raise your glycemic index. They really pump us to high levels. They're very, very strong, very intense. And that's why they've been outlawed in other countries, but not here. So when you see, like, for example, our sodas, high fructose corn syrup is too sweet. It's too much sugar. They also have done studies where they pumped cancer cells with high fructose corn syrup, and they noticed the cancer tumors grew just because they were pumped with sugar. Because again, if you think about it, cell growth and proliferation, even in an unhealthy sense, such as cancer, sugar can propel that growth as well. And if you're taking in that high concentration, some of those bad sugars, then that certainly can contribute to problems. So carbs in moderation are good for us. There's nothing wrong with occasional rice, and brown rice is actually good. Quinoa, those are healthy carbs. So finding those things are going to be extremely important.
Okay, I'm not seeing any hands raised or in any questions in the chat, but I do want to raise one more thing before we close out today. And you mentioned about sitting at the desk and what that can do to contribute to diabetes. And I've heard the term, like, sitting is the new smoking, because we're all
Yes.
like here in front of Zoom a lot, all day long, almost every day. So can you touch on that, maybe what people can do to prevent some other health conditions that may be related to or stem from being more sedentary every day?
Yeah, absolutely. If you guys have ever done research, look up the Blue Zones Initiative. And the Blue Zones Initiative is where, and it's actually out of California, Adventist Health is connected to the Blue Zones. And those are 5 areas around the world where they have the most centenarians, or the most individuals who have reached 100 years old. And all of these people who live in Osaka, Japan is one of them. Loma Linda, California is one of them. There's a place in Italy that's one of these cities, and they're all, they eat fish, from the sea. They exercise, they stay active. It's very important to know that where all these areas, people are extremely active. They're moving. They're not just sitting there, and it's great to work from home. I've worked from home almost 20 something years, but I had to buy one of these desks where I can raise my desk and stand up, while I'm talking or in a presentation or in a meeting. Those are some options. Setting a timer where you can get up, you can get the little foot kind of thing where you can kind of move your feet like you're on a bike. Just really trying to find an options where you're not just sitting there. Set a timer where, hey, every hour and a half, I'm going to get up and walk around. I'm going to go and refresh my drink, my coffee or my water, or whatever, get some tea or something like that. But just trying to stay as active as possible, even when you're working at home, because unfortunately, again, yes, physical inactivity is the new smoking, and you're seeing significant health issues as a result of just people not using the body, using their bodies the way they should. Because again, remember, if I work out and if I exercise, I am mechanically putting I'm putting glucose inside of the cell. I'm doing it myself. I'm taking my personal responsibility and making that glucose, that sugar, go inside the cells to be used. So that's where you can do something about it physically yourself. And that's a just different way to look about it. It's kind of like, I'll make my own table. I'll go cut down the tree and put the wood together and make my own table. That's what you're doing when you exercise. And that's just a different way to view it.
Okay. And then very quickly, there is a question around the relationship between, I think you mentioned this earlier, the correlation between muscle development and the linkage with diabetes. So someone wants to clarify the role of that and that connection.
Yeah, absolutely. So if you remember, one of the things that I talked about was that in the regular system, like when we take sugar in and it goes in our bloodstream, what sugar does is going to give our body the fuel it needs, specifically our cells. And one of the main cells is our skeletal muscle cells. Those are not all of our cells, but those are just, our cells, our muscles, right? And when you get insulin's job is, when it's released, it goes to the muscle cell and it kind of puts its key in the lock of that cell. The cell opens up, glucose goes in, and then it gives it the ability to function and do what it's supposed to do. So your sarcomeres, they stretch and they break and they get longer. They hurt because we've been working out. You hurt a couple days later because lactic acid is coming from them. But what they're doing is they're expanding and they're growing and they're doing everything that they're supposed to do. Well, they can't do that if they don't have glucose that they need in order to function properly. So it's a very intricately intelligent system whereby you take in glucose, insulin goes into the muscles, it opens the door, glucose goes in. But what happens in type 2 diabetes? Type 2 diabetes, that system is messed up. The sugar sits in your bloodstream and it oxidizes. And that's what I was talking about last week. You have the rusting of a car or you have the browning of a banana, and that leads to the destruction and problems in your body. So skeletal muscle and working out helps you to continually use that sugar that you need, and then your muscles get stronger and you move towards being as healthy as possible.
And then just very, very quickly, do you think across cultures, especially in the African-American culture, women are the primary decision makers about what about their children's nutrition?
Oh, 100%. Absolutely. Yeah, yes. I do believe women have a strong role in how our kids eat. Certainly, that's why it's so very important that, we understand our history. And a lot of times we've cooked the foods going back to, when you think about Jim Crow and going all the way back, why did we cook all aspects of the hog and the pig? It's because, those were some of the animals that were made available for us. It wasn't about choice meats. It was about what was available. And we perfected that. But at the same time, it's had an impact on overall health over time. So it's important, for our moms to know all health options that are healthy food options that are possible, understanding, how to economically shop for good fruits and vegetables, healthy fats, healthy, instead of, junk food, avocados for snack, put a little salt on there, and do that. You can do sea salt and just put a little bit on there, and helping kids learn how to eat as healthy as possible, instead of instead of some of these unhealthy options. I'm gonna tell you one of the unhealthy thing, Rhonda, and I'll throw out there too, is the kids are eating things that are so inflammatory. So like the Takis chips and the really, really strongly spicy things that they're taking in that are contributing to a lot of gastritis, inflammation of their stomach linings at early ages. Like we're seeing that unprecedented, in terms of in our emergency room. So just helping moms encourage the kids to eat as healthy as possible. That's what's important.
Okay. And I know we're on a tight time schedule today. Marcia, I will follow up with you to make sure your questions get answered. And I have a few other questions that I wanted to ask Courtney, but we are on a tight time schedule today. It just never seems like there's enough time to get through all the information or have the kind of conversation that we want. So we'll make sure
Can I answer this one last question I saw?
For
the
sure.
one on once diabetic, always diabetic.
Yeah.
Not necessarily true. You can move towards reversing diabetes. I just want to encourage you guys. You can type 2 diabetes, especially. Now, type 1 is different because that means typically it may be autoimmune and you have beta cell death. So you are going to need insulin. You are going to need possibly help with that. But in terms of once a person diabetic, always diabetic, in type 2 cases, that's not true. You actually can move towards going into a remission and being as healthy as possible, as long as you eat healthy, maintain good exercise, and do some good habits. So thank you.
Great. Thank you so much. If you have any questions that crop up after or come up after today, please send us an email at askcbhn@cbhn.info. You can always follow and connect with us on social. It's very easy to remember. It's at your CBHN on Facebook, Twitter, as well as Instagram. And we're the California Black Health Network on LinkedIn. We have a few other events coming up. One actually right in a few minutes, which is on the intersection of DEI and health equity. And then we also have the third part of the 5-part series of Let's Dismantle Diabetes that's coming up in a couple of weeks. So it's May 18th, so please note that on your calendar, and we'll talk more about treating versus treatment for diabetes. And also, again, we're celebrating our 40th anniversary this year. So those of you that are in the Sacramento and San Joaquin County areas, please join us next Friday for our event in Sacramento. So thank you all for joining us today. We hope you have a great afternoon. If you can stick around and hop into the next webinar, please do so if you're interested in the topic. But otherwise, have a good afternoon and thank you again.